So there's two things that's been bothering me.
Okay.
So when I was in school, the planets, Mercury, Venus, Earth, Mars, Jupiter, Saturn, Uranus, Neptune, Pluto, right? Those are the planets. Except then they decided that Pluto wasn't a planet anymore.
They didn't just decide it. They found out that it wasn't.
How did you just find out?
Because it wasn't large enough or didn't have a gravitational pull in the way.
So anyway, that's not fair. Second, kingdom, phylum, class, order, family, genus, species, right? They changed that too, I found out.
What did they change that to?
I don't know. I still remember the old way. So it's just irritating me because one, what is real? And two, science clearly isn't real. So let's talk about medicine.
What? You don't know the change? You really don't know the change?
No, I don't know what it is anymore.
Did they take something out or add something in?
Who knows? Nothing makes sense. Science is not real.
I'm going to be honest with you. I don't have the planets memorized in that way or the order memorized in that way. I think that's useless knowledge anyway.
It is.
You know what I can tell you about? What Mace Windu uses
No.
in terms of force ability. That's where my knowledge goes.
There you go. All right. Anyway. Well, welcome everybody to the Back to Basics podcast with Chris and Jason, sponsored by Guardian Test Prep pretty much every time because we are also Guardian Test Prep. If you're studying for your national registry exam, check us out, guardiantestprep.com. We've got everything you need to help you pass that exam.
But what if you're not studying for the exam, Chris? And what if you need continuing medical education credits?
I'm glad you asked. So we are super excited. You guys have probably heard us talk about it before, but we are super excited that it is finally time to launch Guardian CME. Guardian CME, guardiancme.com is 100% free CAPC credits. This podcast, content from EMS 2020, EMS on Air, other great content contributors are all going to be hosted on guardiancme.com. CAPC credits for all of it, and it is 100% free.
What does CAPC credit mean?
Go ahead.
Well, easy. It doesn't matter what state you're in or what country you're in. You will get approved to use this CE. So hypothetically, like every state's different. Here in Michigan, we're a little bit different than Ohio and Illinois and so on. I'm not going to name all 50 states. Another thing I didn't. But basically, you can find a credit with the topic area that you need it in, and then you can submit that to your state. And 99.9% of the time, your state's going to say, hey, CAPC, we trust that organization. You're good to go. So think of it as a universal credit. Mm-hmm. So you will always be good to go no matter what state or country you're from to get your education.
Like I said, so if you want to register on there, again, 100% free for now until we realize we can't afford it anymore. No, so it's guardiancme.com. Basically, you're gonna make up a sign-in. You're going to put in your NREMT numbers, your state license numbers, all that kind of stuff. That way we send all that information automatically to CAPC. So they have record of all that. You're going to get a certificate at the end of each piece of content after you take a quiz. Like I said, awesome resource. We're super excited about it. December 13th is our tentative official launch date. That should be the day that you should
2021.
Of 2021, yes.
So if you're listening to this in the future, you should be listening to this on the LMS for a free CE.
Exactly. And that is the cool thing about it. So guardiancme.com is not just a CME website. Guardian has built out our entire own learning management system. So basically that content is housed there, and just like I said, a great resource, lots of great content providers on there. We're excited to be pushing that out, and hopefully if you're listening to this and you want to get credit for it, go check it out over there, take a quiz and get your credit.
Or if you're sick of listening to us, there's other people on there too that you can listen to for credit.
That's true. So awesome. So today's topic, we're kind of starting like a 3-part series.
You said right 5 minutes ago, guys, he said, don't say that this is a 3-part series because we're not going to do these back to back.
Well, I was just going to say, that's what I was going to say. It is a 3-part series,
yes,
but they're probably not going to be released back to back. We might have a Q&A. We might have another, we have some, we want to kind of link up with EMS 2020 and EMS on Air, maybe share some of their stuff. So this is one of 3 parts, but it's not going to be released back to back to back.
Pediatric assessment.
Yes.
Part 1. That's not really pediatric assessment part 1. It's just pediatrics. Part 1, assessment, semicolon, are you ready?
Right. Perfect.
Got it.
Awesome. So why don't you tell us a little bit about what we're going to talk about today?
So today we're going to be talking about pediatric assessment, and what we like to do is we take what we've learned from PALS, from PEP, from courses like PHTLS, things where we kind of learn pre-hospital care, and we've kind of put that together into a simple, easy to digest way to approach a pediatric patient, assess them, and then quickly get to the intervention phase, right? We know that children, babies, young adults are not just small versions of adults. Like that's something we learned very quickly in medicine. Mm-hmm. We do have to treat things differently, and we have to kind of approach these patients in a different way. So we're going to break down that kind of assessment chain for you to make it easier. In our following two parts. We will start covering kind of the major emergencies that we see from pediatrics and how to kind of just break those down into simpler, easy, manageable chunks so you can kind of have a little bit more of a checklist on scene. Because I think a lot of people get really nerved out about pediatric calls. When we did like our OB-GYN lecture, we talked about that a lot too, where it's like, you know what, people like, as much as it's easy to deliver a baby and stuff like that, people tend to be a little bit nervous because we see a very small percentage. It was funny. We had a training at my fire department recently where one of our other ICs was teaching the class. His name is Damon. He's a great guy, good friend of mine. And he was breaking down our calls for this year. And he said, you know, we've had 4,000 calls. And out of those 4,000 calls, we've had 100 pediatric calls. And out of those pediatric calls, I'm generalizing the numbers, but out of those pediatric calls, the ones that were critical, there's 5. So it's like in a year, you know what I mean? At a fairly, like I have a smaller department, so 4,000 calls is a lot for the amount of people we have, but for a fairly busy department to only run on 5, you know what I mean? And you got to be the person who happens to be on that call that day, you know, it is still a very much low frequency, you know, high danger event for us in terms of treatment.
And that's true in the emergency department as well. So I worked in multiple emergency departments throughout the country. And like I said, some emergency departments don't even see kids, right? They have a separate pediatric emergency department. But for the community hospitals I've worked at where you're seeing adults and kids, usually a general rule is that 20% of what you're going to see are kids in the emergency department. Now, that's not sick kids, right? That's kids with an earache and, you know, need stitches. And so again, the goal here when we talk about this assessment approach is basically the key, because we're talking about emergency medicine, the key thing we're trying to figure out is this kid critically ill or not critically ill? Do I have time or do I need to intervene immediately? And really what the entire goal behind starting our assessment this way is to prevent kids from going into cardiac arrest. Exactly. So again, as we build this out, you'll see us, we'll talk about some of the two things that can push a kid into a cardiac arrest type of situation. Now, based on this assessment, are you going to be able to diagnose everything a kid has? No. Are you going to be able, though, to say, hey, this kid is sick and I need to intervene early? Or, hey, you know what? I think we've got time. We can get him to the hospital. We can, you know, have someone else take over care. Yes. And that's kind of the main goal of this assessment technique.
And it's the most common and it's the most, you know, we're going to take the emergencies. Like when we break down airway emergencies in a couple of weeks here, like we're going to take the most common airway emergencies. Now, is this every single thing that can happen to a kid? No. Right. But it's going to give you the most common. It's going to kind of give you these treatment modalities for kind of checking those boxes and making sure that you can take care of anything. Before we get into the assessment portion, I do want to just talk a little bit about like why kids are so different than adults and talk about maybe how they compensate. We know that they compensate a little bit differently. And
they're smaller.
that is one thing that's very different. They are smaller, Chris.
I'm like, nailed it.
But what are some other big changes that we see with kids?
Sure. So a couple things we see with kids is one, like you already mentioned, their compensation, right? So children, I guess we will say compensate much more better. They compensate much better than adults do, probably for a longer period of time before they start to decompensate.
Yeah, two things there.
Right.
Much better. And for a longer period of time, right?
Exactly.
So like we always talk about when we're teaching lectures and stuff like that. Like what's the difference between me and a little child when it comes to circulation and compensation? Like what their vessels can do versus mine. Well, 30 years of eating a bunch of crap, right? Burger King, McDonald's, whatever, right? So this child typically has an incredible circulatory system in the sense that it can compensate for its lack of blood pressure by constricting those vessels and shifting fluid a lot better than someone like I can.
Exactly. And the thing is that because they can compensate for a longer period of time, and this is like, when we say longer period of time, I'm not actually talking about like set minutes. I'm talking, it's not like an adult can compensate for an hour and a kid can compensate for 2.
Sure.
We're talking about based on the mechanism of what's happening.
How healthy they look.
Yeah. If the same thing was happening to an adult, they wouldn't be able to compensate probably from a circulatory standpoint as long as a child can. But that being said, when they start to decompensate, they decompensate much more quickly than an adult does.
Correct.
And that's why this assessment strategy that we're talking about, why we're emphasizing pediatric assessment is so important. Because if your kid is decompensating, you're very far behind the 8 ball in that way, in the sense that like you don't have much time now. With an adult, you'll see their blood pressure get soft, right? What we say like soft blood pressure, like, oh, now it's in the 90s, now it's in the 80s, now it's in the 70s. Kids will have like normal blood pressure and then just not have a heart rate anymore. I mean, they decompensate so quickly. So again, so much emphasis. Now, assessment is always an emphasis we put on all patients, including adults, but especially in kids. Going through something systematically like this and really assessing to really figure out, are they sick? Are they not sick? Are they compensating? Are they decompensating? It's critically important because when they start to decompensate, it will happen fast.
Yeah, and I think an easy way to put this is that if you identify through this assessment that a child or infant has impending failure, you will see failure.
Sure.
You know what I mean? If you sense impending failure, you will see failure. We're going to talk about the pediatric assessment triangle in a second, but basically, we've ran some statistic. The science community. I know you don't believe in science.
I don't believe in science, so
but the science community, the medical community, has kind of ran some numbers and found out that like any time that there's an issue with this pediatric assessment triangle, it's identified. It was something around like 5 to 10%. Well, that's opposite. So 90 to 95% of the time, that patient ended up needing advanced care in the ER. So when we see these red flags, understand that the decompensation is happening so quickly, you will see failure. We're going to need to intervene and intervene early and aggressively.
One thing too, and I'll start, and then we should jump right into the pediatric assessment triangle piece. Now, you guys have probably heard some of these things before. Hopefully you have heard these things before. But again, the way we're going to talk about it and the way we go through it, I think hopefully simplifies it, takes it back to basics. That's what we do. But one thing I will say is that when assessing a kid, if you think this is just I like general rules. I always have, like I said, that's why we do this podcast, but I like general rules. If you think a kid is sick, they're sick.
Yeah.
Just go by that. Like you see kids. I mean, even if you don't have your own kids, you're out in the world. Like you see healthy kids every day. Sometimes I think and I do this at least in my practice. Like if I see someone in the emergency department, because of the context I'm in, I am expecting them to not look healthy. So that I almost like diminish in my mind how sick they potentially are. Mm-hmm. And I do this with adults too. I realize that like if I saw an adult, like I'll walk into an emergency department room and have a patient who's like in pain or something's going on or they're sick. And I'm kind of like, oh man, like so dramatic. But if I saw that guy like at the bus stop, I'd be like, oh my gosh, what's wrong with this guy? Right. Yeah.
Someone help him.
Right. Exactly. Right. Yeah. So even more so with kids, like if you have an inkling, if you're like, you know what, this kid just doesn't look right. They don't. Mm-hmm. I mean, they probably don't. I mean, I would say they don't not even probably don't. They for sure don't. Because if you have that idea, if you feel that way, it's usually true.
So when we talk about assessment, let's just kind of break down, take it back to basics, go to just how we assess in general. An assessment is broken up in pre-hospital care and in emergency care in a number of ways. The first assessment that you do is also the initial assessment. Now, this is a little bit more, it's easier to gear this towards pre-hospital providers, but this is basically, I joke around a lot and say like, this is like, do they look like crap or do they not look like crap, right? Your initial assessment is basically your first gut impression at the door or, 5-6 feet away from them impression of how that patient is doing. And this is when we can apply the pediatric assessment triangle. And this is where I think we mix things up is we think that this PAT replaces your A, B, C, D, E. It doesn't. It just is something you would do before.
And that's the thing is because like we call it the initial assessment. That's not the primary assessment. It's
right.
Like it's initial assessment, primary assessment, secondary assessment, which we'll break down.
Right.
But again, that initial assessment, and I teach this even to like our residents and stuff as well. The initial assessment, like you said, is what do you see at the door before you talk to the kid, before you talk to mom, before you do any kind of physical exam, before you touch them, before you communicated or engaged with them in any way, shape, or form. What is your initial, and that it kind of goes back to what I said. Like if you think they're sick, right? And then we're kind of like taking a moment not to leave that up to chance, but to say, okay, I'm going to cognitively take a second to assess this kid this way. I'm not just going to rush in and potentially miss that, like you said, that kind of gut, like, something's off here.
Right. And for those of you nerds out there who are going, well, you missed scene size up because that happens before initial assessment. We freaking know. Okay. So obviously make sure the scene is safe before you approach, make sure you have proper equipment on, and then you go ahead and you can get your general impression of the patient with the initial assessment.
Yes.
And the initial assessment for a pediatric patient, we use what's called the pediatric assessment triangle. And this is going to be using ABC, but not airway, breathing, circulation.
What?
Airway, breathing, circulation. It's not that. It is appearance, work of breathing, and circulation. So they really only changed one. I don't really know why they had to put work of on there, but whatever. So these are the three things that we want to try to get an idea of as we approach the patient. And these are things that we can do simply by, visualization as we're coming up onto the scene or we're coming up to the patient. This can be done, if you're good, this can be done in 15, 20 seconds sometimes. Sometimes it takes a little bit more investigation, but it should kind of turn on that index of suspicion of, okay, where am I going to look further when it comes to this?
And I will say too, like, this is not something that, like, the more experienced you get, the more it just happens automatically and you don't think about it anymore. If you're not thinking about it, you're not doing it.
Yeah.
And then really, because like you said, if it becomes second nature, you're like, well, I'm sure I'm doing that in my head. No. You really need in your head to be being like, okay, appearance, circulation, work of breathing. Mm-hmm. And appearance is more of like, think of appearance as more of like neuro. So it's not ABC's airway, breathing, circulation. That's the primary assessment. The initial assessment is literally like mental status, circulation, and breathing. Kind of look at it that way.
Yep. So what's kind of fun about the pediatric assessment triangle? I don't know if it's fun. That's a pretty dirty thing.
Is that it's not a circle,
but that's 3 points. It's the strongest shape. No. So if you look, I wish we could. Let's try to bring up an image on this one if we can. I know that we don't do that too often, but if you guys are watching visually, we're going to try to bring up an image for you so that we can show you the triangle, and it's just literally just a triangle that says appearance, breathing, or work of breathing and circulation on it. But if you look at and you highlight the sides where you're seeing the symptoms, so if I'm seeing symptoms of, for instance, appearance and circulation, but I'm not seeing any symptoms in the breathing side, well, that would tell me that they're most likely in shock. If I highlight just the appearance issue, it's probably, like you said, a CNS or a neuro issue. If all three are highlighted, well, I have cardiopulmonary failure at this point, right? This is a big problem. Like, my circulatory system is shot. If I just see the top two, so appearance and breathing, then it's most likely that I'm in respiratory failure, right? Mm-hmm. If I just see work of breathing, I'm probably in respiratory distress. So you can this is kind of new to me. I've used the triangle for years, but seeing kind of the highlighted sections and being like, oh, I can now like subcategorize like what kind of issue I'm looking for is helpful when we get down the line, when we start describing your primary assessment.
I'll just throw in here quick. If you listen to us on like Spotify and that kind of thing, all of these podcasts are also video recorded on YouTube. So you can find us on YouTube, Guardian Test Prep. And then obviously if you're going to guardiancme.com to get credit, you'll see our recordings there. So when he says talking about images popping up, we'll do that on our YouTube. So
cool. So we'll start with appearance. What are we talking about when we talk about appearance? Like what they look like is what you're saying, right? Mm-hmm. So, and we're also thinking those CNS neurotype symptoms. So the first thing that we talk a lot about is tone. So when I say what is the pediatric patient's tone, what do I mean by that?
Well, you mean like kind of like their muscle tone? Like are they moving around? Are they like laying there limp? You know, I mean that's what we talk about, like tone. We're talking about like muscle tone.
So the worst version of this would be they would be like flaccid.
Yeah,
right?
Right. They're just like laying there limp as can be, right? And again, like I said, with a lot of this, you're taking appearance as a whole thing. So you're looking at this kid like, are they acting the way they should act? Are they talking the way they should talk? Are they looking around the way you would expect them to be looking around? And this is why, like, sometimes those are a little bit hard to like quantify, but that's where I say, like, if you're not sure, if you're like, they're probably not in the appropriate state.
Right. So we look at tone, then we look at interactiveness. So this is a pretty simple one, right? Are they interacting with their environment? And this can be, hey, are they making eye contact with you? Are they the appropriate age for this? And are they making eye contact with you when you walk into the room? Do they seem to be, is their head moving towards the loud noises in the room? Are they trying to engage with mom? Or are they just completely zoned out looking and spaced out? Should any child ever be spaced out and looking out distance, not paying attention to their surroundings? No, there's not really any age that's appropriate for that to happen.
Even if you wish there was.
Okay, Chris. How's everything at home going? Next would be consolability. So now kids cry and kids get upset, and they can get upset easily. What do we mean by consolability then? Like, what do we?
Well, I mean, I think people are like, you recognize, like, if mom picks the baby up and starts to like hold them, like the crying gets less. Like if this baby's like screaming, crying, and like nothing you're doing is making it better, like something's wrong. I mean, there's pain, there's something going on.
Like a high pitched cry, and things like that. That's just not going away with, like you said, a change in the environment. That's a concern. They're inconsolable now, and that baby's sick. Their look or gaze, again, this kind of goes with the interactiveness, right? If they're zoned out, they're looking in the wrong area, they're not moving towards sounds, things like that, then they're just ignoring their environment because they're exhausted, because they're decompensating. And then lastly, speech or cry. So is their speech appropriate for the age group? Meaning, does it seem like they're altered? Or again, inconsolability with their cry. Does their cry, if they're an infant, so they don't speak, but is their cry off? And who are we going to ask? How are we going to find out if their behavior is off?
Well, we're going to ask mom, but not yet, right? Like
Right.
this initial assessment piece, like we're kind of assessing this for ourselves. But yeah, absolutely. Like, I mean, if you want to know if a kid's in their normal state or not, you ask the parent. I
Yeah.
mean, those
You said mom. I mean, I think you could ask the dad too, or the caregiver. Or
No,
whoever,
I mean,
but,
as a father, don't ask the dad.
So yeah, you know,
Yeah, I don't know.
these
I
are
don't know who
things.
this kid is.
These are things where it's like speech cry. Like you're checking down your list, you get to speech cry, and you're like, that seems off to me, kind of. Okay, well, there you go. There's your index of suspicion that increases it, so that there's questions to ask down the road, right? As we're approaching, we see these things, and then we can start asking questions to mom and dad.
Mm-hmm.
So next, after appearance, we move on to looking at the work of breathing. So this is pretty simple. This is like a normal airway assessment. A lot of times, is their airway open and patent? How does it sound? What are their breath sounds like? Now, people think, well, you said it's as you're approaching. Well, I'm not saying listen with a stethoscope yet.
Right.
You can a lot of times hear wheezing or rails or, Strider, choking, the lack of breathing, things
hear.
like that as you're approaching, right? So pay attention to those sounds. Pediatric patients, and we'll cover this in a couple weeks when we do our next part, but pediatric patients are like so sensitive to airway problems, right? We talked about their ability to compensate and their very healthy cardiovascular systems. So 90% of the time, pediatric patients code because of an airway issue, right? So they're very sensitive to airway issues. And a lot of times you can fix an airway issue just by positioning. You don't necessarily have to intubate or use crazy aggressive maneuvers. They're very sensitive to that sort of things because of how their airways work. So sounds are a little bit more obvious in a pediatric patient than they would be in an adult, in my opinion.
Yep.
Other things that we look at, abnormal positioning. So is the pediatric patient get a tripod like a COPD does? Kind of.
Yeah.
You know what I mean? They're going to move. You're going to see them position their body and their torso in order to get the most amount of air. That's just a human instinct, right?
Like no one who's having like terrible shortness of breath or even a little bit of shortness of breath is like laying back in bed, relaxing usually, right? They're sitting up, they're sitting forward, they're tripoding. Yeah. So we're looking at those. And the other big thing too is we're looking for retractions. So we're looking for now, if they still have their shirt eyes, this is another reason that when we get in there for our primary assessment, we need to undress the patient. But like, do we see, in the clavicle area, do we see retractions? Do we see retractions in their ribs and their belly? Are they belly breathing?
Why don't you explain what a retraction is for people who might not know?
Sure. So retraction.
I do know. I made it sound like I don't know what a retraction. I'm going to explain it so people know that I know what a retraction is.
Okay,
it's
go
when
ahead.
the skin is pulling to the basically to the muscle or to the mass of the body of the torso because they're pulling in air and you're creating like a negative pressure. So all of a sudden the skin is pulling tight. So if you see skin pulling tight in the neck or the clavicles or the sides of the abdomen, those are called retractions. And I knew that.
Good for you. Awesome. The other thing we're going to look for too is like nasal flaring. Like nasal flaring is another, kids are what we call like obligate nose breathers, especially like infants, I guess more are like obligate nose breathers. So like because of their bigger tongues, and we'll talk about airway things in kids at some point, but because of their bigger tongues and that sort of stuff, like they breathe through their nose. So when they're struggling to breathe, you'll see like nasal flaring and things like that more obviously than you would in an adult.
Yeah, kids can also, it's pretty common for them to be belly breathers a little bit. Like you'll see their belly moving in and out when they breathe. What we're looking for a lot of times that's a big risk is if we see like seesaw breathing. So if you see their chest moving opposite to their belly and it's very significant belly breathing, okay, that's a concern, right? That's an increased work of breathing. Now we're really pulling, we're really using those muscles.
Yep.
And these are things like we talked about. We don't see this in adult. You don't see nasal flaring in an adult usually, right? We're mouth breathers.
Right.
So you're not going to see retractions in an adult as much. I mean, because you've had fatty tissue buildup and muscle development and things like that. You're just not going to see those things. So that's why, babies, kids are not small adults. We're learning new assessment techniques for them. So why don't you take us through circulation now?
Sure. So we did appearance, we did work of breathing, now circulation. And again, like we're taking a lot of time to talk about these, but as you said earlier, it's not
30
difficult.
seconds.
You could be like appearance, okay, yeah, that looks good. Breathing, work of breathing, yeah, okay, okay, good. And circulation. So circulation, again, we're not getting a blood pressure. We're not like listening to the heart sounds. We're not even checking a pulse at this point. We are looking at what can we see from the door from a circulation standpoint. And that's usually going to be like color, right? So that's going to be, do they look pale? Do they look flushed? Do they look, do they look gray? These types of things, right? So we're going to be looking at their general color. And then we're going to be looking as a part of their color, like, do we see mottling? So mottling is where like you have like almost like purplish gray spots.
With patchiness.
Yeah, like
it's very hard to
patchiness.
explain. If you've
It
seen
is,
modeling,
yeah.
you'll know it. Look it up. Google modeling. That's your
modeling.
homework. But it's like,
not
yeah, it's like
modeling. I mean, you can Google modeling, but we're talking about modeling.
with a T.
Mottling.
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 Don't
They're
look up
like, I don't know,
babies.
these guys look great.
Don't look up babies modeling.
Baby models. They look great. Their color's excellent. No. Mottling. So, like I said, it's kind of like this like patchy discoloration of tissue. And it's because, like I said, circulatory wise, things are shifting. So some areas are getting perfusion, some are not, even in the skin. And then cyanosis. So cyanosis, like lack of perfusion, is going to show up like, blue tissue, gray, blue, gray. Again, this is all based on color. So what
Cyan meaning blue.
yeah.
Cyanosis.
Mhm.
People forget that. People always be like, are they pale? They're pale and they have cyanosis when they give scenarios and stuff like that. And it's like, they can't really have both.
Yeah, that's true.
I mean, I guess you can have like lack of pigment and then also the pigment's blue. But that's a good another point though, is what happens if you have someone who has like a darker skin, like a darker pigment to them? How am I going to notice pallor modeling, cyanosis, things like that? Like, where would I look for that?
Well, a lot of times you still will see it. You know what I mean? Like, it's a little bit harder to see. But the other thing you can look is like, look at their mucous membranes, right? So you're looking at like their lips, you're looking at, like their ears and things like that. Like where the tissue is thin, right?
Mhm.
Is where you're going to see that.
And you can look at eyes, nose.
Head, shoulders, knees,
I was
and
gonna
toes.
do it. I was waiting for it. Okay. Anyway, no, but like, yeah, mucous membranes. So areas where the skin is thin, and then also the literal mucous membranes, your eyes, nose, inside of the mouth, like underneath the lips. Again, that's an assessment thing that we start to notice. Hey, they look a little bit dusky. We're going to move towards them now, and then we're going to identify these things or further identify these things in our primary assessment.
And you can see now, so that's the pediatric assessment triangle, right? We've got the appearance, we've got work of breathing, we haven't even touched the patient, we haven't assessed them, but we can already say, do we think this kid is sick or are they not sick based on our pediatric assessment triangle? And we can already start to say, okay, I think this might be a respiratory issue, or I think this might be a circulatory issue, right? Because these are the two things we're trying to delineate from as we work through this thing. Are they sick? Are they not sick? Do I think it's a breathing issue, or do I think it's a circulatory issue or shock? Because those are the two things that are going to put a kid into cardiac arrest: respiratory issues and shock. So are there lots of other things that kids can suffer from? Yes. What are the emergent things though? And 99% of the time, it's going to be one of those.
Right. People think that like PALS and PEP and stuff like that is basically ACLS for pediatric patients. And
Right.
it's not, right? ACLS is advanced cardiac life support.
Right.
PALS is pediatric advanced life support, right? We're not talking about cardiac rhythms as much in PALS, because we're way behind the eight ball if we got that far.
Right.
And the reason that they're going into dysrhythmias and stuff isn't because they have an unhealthy heart. It's because they most likely are suffering from a respiratory or shock issue.
Exactly.
Right?
Yep.
So we start to kind of piece that together with using this triangle. So then we would move on to our primary assessment. So we've done our initial assessment. Now we're on our primary assessment. We've approached the patient. We want to tick off the life threats. And this is the same thing that we do with adults in terms of, listing the process. So we're going to check the airway, your A, B, C, D, E, right?
Mm-hmm.
The airway, is it patent? Is it open? Is there an obstruction? Their breathing, we've already looked at their work of breathing. Now we can look a little deeper if we'd like, right? Their circulation, this is when we can check a quick pulse. We can get a pulse rate, things like that. Their disability, this is the D and the E is what everyone forgets. Disability would be, we're looking for like neurostatus issues, right? So this is where we could rule out things like blood sugar. We could rule out things like head trauma that's causing some sort of neuro change. And again, who are we going to talk to discover disability issues? We're probably going to talk to the parent, right?
Mhm.
Especially depending on the age of the child, right?
Yeah.
And then E is exposures. So exposures would be what in their environment could have potentially caused issue. Is there trauma involved? Was there a poisoning? Am I concerned about
Burns.
electrolyte imbalance? Yeah. Is there burns? What am I looking at on the outside of this?
Mm-hmm. Yep, exactly. And again, those A, B, C, D, E. So we're doing the same thing. So we're starting with airway. Is it patent or not? The best way to tell if an airway is patent is the child talking, making noise, that type of thing. A lot of times, right? Breathing. Now we're listening to the lungs. Do we hear wheezing? Do we hear rales, rhonchi, stridor, all that kind of stuff? We're reassessing their work of breathing. We're getting a pulse ox, things like that. C, circulation. Okay, blood pressure, capillary refill. So that's one I want to talk about with kids. So we really should be probably trying to do capillary refill on everyone. But if you're someone who has COPD or emphysema or coronary artery disease, like your capillary refill may not be very accurate.
Even if it's cold outside, like our sister Kendra has like poor circulation in her fingers in general. If I was judging my assessment only on capillary refill on her as an adult, she'd go to the hospital every day.
Right, exactly. But in children, capillary refill is a very can be a very obvious and missed sign of circulatory issues. So you want to talk about capillary refill?
Yeah, it's assessment of the peripheral perfusion. You basically just squeeze the finger or push on the nail bed, and then you're looking for that color to return, right? So we're seeing that there's a lack of color as we push it, we depress it, there's some pallor there, and then we're looking for that red or pink to rush back to that area. And it shows us, as distance as we can be from the heart, at the tip of the finger, we're seeing where our perfusion is at, where the fluid flow is at.
If it's less than 2 seconds, so if it takes longer than 2 seconds for that color to come back to the nail bed, that would be what am I trying to say? Like an
unstable patient.
Increased capillary refill, which shows that there's a circulatory issue.
You'd have a delay circulatory filling time in the sense that like, we're not getting the perfusion to that area as fast as we want.
Exactly. So, and it's a really good thing to assess because we talked about how kids compensate really, really well, right? So their blood pressure is not going to be that's going to be a late finding. If their blood pressure is getting low for their age group, that's going to be a very late finding of circulatory compromise. Capillary refill, though, could be an earlier sign.
Absolutely.
And with kids, because they do, we like to say sometimes that they hide things, and it's not that they're like purpose, but because they compensate so well, sometimes it may be only one of these little things that is your only clue in that, hey, there's a circulatory issue. So let's say you did your pediatric assessment triangle, and you're like, they maybe look a little bit, they look pale, but it's also winter in Michigan, and I don't know, like maybe something's wrong, maybe it's not, but I'm including into that. Now their work of breathing's fine, their airway sounds good, it's patent, their blood pressure's nice and stable, their heart rate seems fine, but then you do capillary refill and it's 3 seconds. Well, now I thought the kid was pale and I've got a delayed capillary refill. Now I'm very much clued in on like, okay, I think there might be a circulatory issue here. I haven't figured out what it is yet, but there might be something. Those are very easily missed. If you didn't take the time to really think about like, do they look pale? And you didn't check capillary refill, you would have missed it at this point, right? Like you wouldn't have found it. So again, circulation, then disability. And the disability exam we like to use is the AVPU scale.
Yeah, I was going to say this. So if we're dealing with an adult, we want to know if they're alert and oriented, right? That's one of the easiest ways that we can kind of check for disability. You're not going to ask a kid, like, who's the president of the United States? Like, where are you right now? What's your address? You know what I mean? You're not, especially like a child who doesn't talk.
Like, here's a question for you. Kingdom, phylum, class, order, what comes next?
There you go. So when you can't ask a child this, AVPU or the AVPU score is a lot easier to kind of use as a quick categorization of where they're at in terms of disability.
So the AVPU scale is they're
fully alert.
Alert means they're fully alert. V means that they're only responsive to verbal stimuli. So P, that they're only responsive to painful stimuli, and U, they're unresponsive.
Yeah. So the verbal stimuli would be like when we were talking about interactiveness and like speech cry, right? If like you start talking or there's a loud noise in the room or whatever, and they're looking up and making eye contact with you, okay, well, they're responsive to verbal stimulus. It doesn't mean that they have to give a verbal response.
True.
And that's where people kind of mix things up. So they don't have to give a verbal response. They need to be responsive to verbal stimulus.
Like if you walk in the room and you're like, hi, I'm Dr. Seitz. What's your name? He's like, my name's Jimmy. And you're like, verbal. Like that kid's alert.
He's alert.
Cool. And then like I said, again, with exposure, and this is really, really important. And when we talk about exposure, we're talking about assessing exposures the child may have had. Like you said, like, burns, hypothermia, like what's their temperature? This is a good time to like think about temperature. I usually think temperature, I think skin. So trauma, burns, things like that. But it also reminds me that if I haven't yet, and I should have in the very beginning, but if I haven't yet, I need to expose the patient. Like you're not going to see retractions. You're not going to see some of this stuff unless you're like, looking under the shirt and that sort of thing. There's been a lot of times where I've walked into a room and kids' work of breathing looked perfectly fine from the door. But then when I lift the shirt up, they're belly breathing. And that was my only clue or sign. So again, keeping that in mind. So that's your price. So you did your initial assessment, right? The initial assessment was the PAT triangle, pediatric assessment triangle. Then you do your primary assessment, which is A, B, C, D, E. And again, now we get to the end of our primary assessment. We're asking ourselves the same questions. Is this kid sick Or are they? And are they not sick? Like maybe the PAT triangle was fine, and I get through my A, B, C, D, E, and they're still fine. Okay, I'm still not finding any signs. I'm not done yet, but I haven't found anything yet. Or I'm saying, yes, I think this kid's sick. And again, I'm asking myself, do I think it's respiratory or do I think it's shock? And I may not know. I may say, you know what? I think there's respiratory or there's also some shock. It may be both. But again, we're trying to zero in on because we're going to eventually get to the point where how am I going to intervene if I need to intervene?
Yeah, it's not just I'll be sick and then we're done. Let's go to the hospital, right? We're going to try to figure out what's going on. And I guess the primary assessment, a lot of times we say is we're assessing for initial life threats. And that's whether it's an adult or a pediatric, right? We're ruling out the big life threats. Is there airway patent? It's not. Okay, I'm gonna jump on that right away.
And that's what I was gonna say. We got that problem. If you run into an issue in the primary assessment, you're gonna do something about it.
Right. So once we've kind of ruled out those life threats, and I think you transitioned very well talking about, hey, we need to make sure we do a head to toe. We need to do a physical exam. That's where our secondary assessment comes in. So I always like to say that the secondary assessment is your information gathering stage now, right? We've ruled out the life threats. We've decided if the baby's sick or not sick, or the kid is sick or not sick. And what we mean by that, guys, really is if we were comparing it to an adult, it would be stability versus instability, right? Are they compensating or are they decompensating? Where are we at with that?
This is one thing I'll throw in really quick too, because in the primary assessment, it's also where we're going to start interventions. And reassessment becomes a key piece here already. So if I come and your airway's not patent and I position your airway with a, jaw thrust or, that type of thing, and now it's patent, like I said, I have to start that over. So if your airway's patent and then I go to your breathing and I find out that you're hypoxic at 88%, I'm going to put you on oxygen. I'm not going to move on to circulation. I'm going to go back, make sure your airway's still patent, go back to your breathing. Did that change, right? When I do something, I need to see if it made a difference. So now is your pulse ox better? Is your work of breathing better? Good. Okay, cool. Yes, it is. Now I'm going to move on to circulation. Yeah. These types of things. So again, we're going to intervene. And as we intervene, as soon as we do any type of intervention, we want to start over again with that primary assessment and reassess as we go through. And I see this happens a lot of times, when we teach PALS courses and do trainings, is that people, sometimes if a kid's critically ill, there's a lot to do in that primary assessment. And then they never make it to the secondary assessment because they've already done so much. They think that kind of the case is over. And that's not the case. What we still need to go on and do that secondary assessment.
Yeah. So the secondary assessment, like I said, information gathering. This is when we're gonna gather information in two ways. We're gonna ask questions and we're gonna use tools, right? We're gonna measure things. So we're gonna get vital signs. That's our tools. Simple as that. And we're gonna get very similar vital signs. There are vital signs that are a little bit more important, like you were saying, like cap refill. You can kind of consider more towards a vital sign here, and it's probably gonna be more valuable than a blood pressure at this point because it gives us a better picture of their compensation value. We might want to use, if we're suspecting a respiratory emergency, we might be more apt to use things like capnography and stuff like that to kind of get a waveform and figure out what's going on, especially with asthmatics and things like that. But then the other way that we gather information is we ask questions. And this is where things get difficult in pediatric calls. It's why we had all of this stuff leading up to this to kind of help us out, is you can't necessarily get a sample history on a child for one of two reasons. One, they cannot give you the history themselves, right? They can't tell you what their signs and symptoms are because they have trouble communicating because of their development stage. Or two, they just don't have a history, right? If I ask, even if I ask mom and dad, hey, do they have any allergies? Chances are the answer is going to be no, because they haven't lived a long enough life to discover if they have allergies, right? So this is where, I think you rely heavily on the signs and symptoms and less on, information that we've gathered, and we're checking boxes, we're writing their history and their medication list, right? Like most children aren't on a plethora of medications. They shouldn't be, right? Because they're young and healthy. So, but this is where involvement with the parents or the caregiver or the person on scene, the touch point for them is going to be important. So we're going to talk about sample history, and then with that OPQ or ST if there's pain, right? So sample stands for signs and symptoms. We've already kind of checked that off. Do they have any allergies? Are they taking any medications? Past pertinent medical history. So have they had any medical history in the past?
And then include the past history will include a birth history too. Were they premature? Depending on their age, right? Like, were they premature? Did they have any issues right after they're born? So make sure to ask those questions too. Did you have any complications in pregnancy, especially if it's an infant or like a young child? Those can be sometimes a good clue. And like if they had, respiratory issues because of different conditions, because they were premature, and now you've got a 6-week-old who's, seems to be having respiratory. You got these things do clue you in more.
Well, it's funny you say that because even with a delivery, you know what I mean? We're doing a pediatric assessment on a newborn now. And that comes into play too. Hey, mom, have you had prenatal care? Like, was there an expected complication in this delivery or anything like that? Right? You can get a lot of information that way. The last oral intake, this would be like, what did they last take or eat? With children and especially with babies, infants, how they're feeding is really important to like how their health has been lately, right? So if they have had poor feeding recently, that's a good sign that, hey, this child has been sick for a while. Like, when was the last time they were feeding normally? Okay, well, this child's been sick for a couple of days now. Well, they could have been compensating for a very long time, and now I'm looking for a crash.
Right.
So last oral intake is very important. And then E, the events leading up to the incident. So, hey, mom, when did you notice the change? What's going on?
And she's like, right after he fell off the roof. And you're like, oh.
There you go, easy assessment, right? So, and that brings me to the second part is we do need to do a head-to-toe exam.
Yeah.
Right, we need to go head-to-toe. We need to check everything. And this isn't just for traumas. This is for medicals too. EMS 2020 just recently did a case that I was reviewing when we were putting it on the LMS where major things were missed because the medic and EMT failed to just do a physical exam, on a car accident of all things, right? So it is interesting. I do think that we get into these habits and we kind of, we check this box or I've done this before. I have this suspicion based on my assumptions on what's going on. We don't verify.
There's a case too where it's a PALS case in the PALS AHA guidelines where the child, so if you go through the pediatric assessment triangle and you notice that they have some kind of neuro and respiratory issues and you intervene on those, you do your primary assessment, you realize that the patient has some circulatory issues as well. So you start giving them some fluids, you start you do all these interventions, but you really don't know what's going on. And then when you get to the head or toe exam, you end up in the case, you end up finding head trauma. So, but what's cool about it is that you've already addressed the life threat. You've already addressed the circulatory status. You've already addressed the respiratory status in your PAT and primary assessment triangle. So you eventually get to the point where you figure out like, oh, okay, head trauma, that's why I'm seeing these things. But even if you hadn't, you've still intervened correctly because you went through the systematic approach. And that's why this is so powerful, is to do this systematically and to do it this way every time. Because we've already said, like, it's very easy to miss these little things. And again, time is brain, time is heart. You hear all these things all the time, right? Like with kids, like when they decompensate, they're going to decompensate quick. So we really want to try to intervene as early as possible.
Yeah. And kids will keep things from you that you might not discover until the physical exam anyway. You know what I mean? Like
your wallet, your phone, your headphones.
Chris is having a rough time during the holiday season right now. No, but they, so as an example, when I was younger, I had strep throat for like a week and ended up getting scarlet fever developed from it because I just didn't tell our mom that I wasn't feeling good. Right. It was just like, oh, I'm just playing and I'm doing fine. Right. So like young kids, we might not notice that there's an injury until we do a physical exam because they're not telling us about it. And okay, now we notice wincing. Hey, what happened to your knee? You know what I mean?
Right.
Or whatever. So just because we get a sample and we get events leading up to the incident, well, we're getting the events most likely from parents. They don't necessarily know. What if they were out in the yard and we don't know, right?
Right.
And then we get to that, he's wincing when we're touching around the knee. Well, this tells me that there's something going on, right? Mm-hmm. And then lastly, with this pain, if your sign and symptom is pain, typically in an adult, we would do an OPQ-ST assessment. And that stands for the onset of the pain, the provocation, does anything make it worse or better, the quality, how would you describe the pain, the severity, the radiation, sorry, I missed R, radiation, is it traveling anywhere, S, severity, and then T, time, how long it's been going on for. And the difference between onset and time would be like, when did it start versus how long ago was that, right? Mm-hmm. Now, is it going to be easy to ask these questions to a pediatric patient? Depending on the age, probably not, right? You're not really going to be able to be like, hey, on a scale of 1 to 10, 10 being the worst pain in your life, how bad is this? It's like, well, my life has been 3 years, so it's the worst, So that's hard to do. But you can get ideas from parents too. Does this seem like an overreaction? Not overreaction, that's a bad word. Does this seem like a excessive response,
Yeah, does it seem like an appropriate response to what you witnessed as the injury or that kind of thing? That's
cool. So that brings us then to kind of our identification stage and figuring out now we have this information. What are we going to do with it? And we're going to get into this in the following weeks when we start talking about pediatric airway emergencies, pediatric shock emergencies, and then we might get into a little bit of cardiac stuff, even though it's rare. But Now we need to identify, okay, is it a respiratory issue or is it a shock issue? And what we're going to get into in the following weeks is, so it's a respiratory issue. Let's say we've discovered that using our PAT and good primary and secondary assessment. What kind of respiratory issue is it? Is this patient stable or unstable? So is it distress or is it failure? Do I see compensation with it or do I see decompensation? And we'll talk a little bit when we begin in a couple weeks here about what those differences are, signs and symptoms that lean more towards distress versus failure. And we'll kind of get into that. And then we'll break it down into really 4 categories of airway emergencies that you're going to see. And then the most common emergencies within those 4 categories. And that's what we'll talk about. The other side of it is if we don't think it's a respiratory issue, it's most likely a shock issue. So in the following weeks after that, we'll talk about, okay, so what type of shock do we think it is based on what we're seeing? And then is that patient compensating or decompensating? So again, stable or unstable, are they crashing? And do I need to intervene very quickly and aggressively?
Right.
And that is assessment.
Yep, exactly. So again, just to emphasize, you're doing the pediatric assessment triangle. That's your initial assessment. You're going on to your primary assessment, then your secondary assessment, and you're doing this systematically. And I really want to encourage our listeners to do this every time. When I started to actually use this in my own clinical practice as an emergency physician, I started to realize man, I feel confident now saying, yes, this kid has an issue that maybe I haven't figured out yet, but I need to keep looking. Or you know what? No, I think this kid is okay for now. And we can do some other tests and other diagnostic things or send them to see their primary doctor and things like that. And you'll gain such a confidence in being able to assess children, because what you don't want to do is kind of quote unquote, do your best and then be well, I hope I didn't miss anything. If you do this, you really are not going to miss anything. I mean, there really is not much left on the table if you go through this systematically, and you will pick up on things that really can make a huge difference in terms of morbidity and mortality for these kids. I mean, I'm not going to share them right now, and I probably shared them before though, but there have been cases where before I did this type of more systematic approach, I did miss a thing here or there. And I'm oh man, would I have caught that had I gone through this? And probably, and that. So I just want to encourage you guys it shouldn't become second nature. And if you find yourself not going through each step independently, take it back to basics again. That's why taking it back to basics is so important, because you don't want to basically have this stuff become quote unquote second nature. And then you start to miss steps, especially when you're talking about kids, especially when you're trying to talk about assessing them for life-threatening emergencies. So that's the big summary right there.
Yeah, don't get complacent, I think is what you're saying.
Yeah.
Don't get complacent with it, and you can trust your system so long as you utilize it,
Yeah.
right? So we've built out a system. I say we, PALS, AHA, PEP, right? The medical community has built out a very nice system for you to be able to assess a child, use it, and then be confident in it.
Yeah, absolutely. So we appreciate you guys taking the time to listen. Again, in the next coming weeks here, we're going to go a little bit farther into this and start talking about what are those respiratory, what are those shock-like states in kids. But again, if you want to get credits for this, go to guardiancme.com. Check us out there, sign up. You can listen to this, take a quick quiz. You better believe the pediatric assessment triangle and all that sample history and stuff will be on there. Pass that quiz, get some CAPC credits, 100% free. We're really excited to be offering that. Thank you guys so much. And Jason, you have anything else?
No, just
all right.
Stay sweet.
Cool. Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.